So good afternoon, everyone. First of all, I would like to thank the organization committee who give us an opportunity to share with you our experience in Central Precocious Puberty management. So next slide, please. So this session gonna be kind of Q&A sessions with we prepare about like 7 questions, which are the common questions about CPP management, and myself, Dr. Karn Wejaphikul from Chiang Mai University Hospital, Chiang Mai, Thailand, and Assistant Professor Dr. Tansit Saengkaew from Songkhla Hospital, Songkhla, Thailand, gonna provide you some evidence to try to answer this question. Next slide, please. And this is our disclosure. So the first 3 questions I'm going to ask Dr. Tansit, and Dr. Tansit gonna provide you the answer. So Dr. Tansit, are you ready?
Okay, great.
Okay, so start with the first question. I think everybody knows that the secular trend of puberty onset is moved forward to the younger age. However, the question is that how does the shift of secular trend of puberty onset impact the CPP management? Do you have any thing that share with us about this question? Please,
Okay.
Dr. Tansit.
Okay, thank you, Dr. Karn. I will start to answer this question with this figure that I'm sure that everyone is familiar with this figure. It shows the secular trend in pubertal onset declining continuously over 40 years. And if we look back to the basics of the definitions of precocious puberty, which is defined as the child having an onset of puberty before 2 SD of sex and ethnicity in each populations. Although in general, the age of 8 years in girls and 9 years in boys are the cutoff, but I think nowadays we have to apply the definitions by the 2 SD as in each country or in our clinical practice to give the diagnosis of the CPP instead of just 8 and 9. And this is the example that I will show you. And in this study, it was conducted in my city or in Thailand, in our area, where the 2 SD of onset of breast onset in girls is start from 7.1. So in my practice, in a girl with a breast onset at around 7 to 8 years old will be diagnosed as early puberty. And the next step that as we are the pediatric endocrinologist, so I think we have to investigate further to decide whether they need the treatment or not. And I will talk to you and discuss later in, I think, the 3rd questions. And there are rising questions that, so if the trend is declining, could we change the definitions of precocious puberty and to lower than 8 years in girl? So I will answer this. Supposed by this study, if you see the result of this study, which study in the 443 CPP patients in Europe, and they found that almost around 11% of the 7 to 8 years old girl with CPP has CNS lesions, which can explain the etiology of the CPP. So if we change the definitions of the onset lower than 8, so we might miss this patient for the diagnosis of CNS lesions. And instead of changing of the cutoff, and many authorized world authorities suggesting that depend on the age of onset, we need to more indicators to apply for the diagnosis of CPP, which including the pubertal progressions, the bone maturations, and the growth tempo. But in this way, sure, we will have more patients referred for evaluation of precocious puberty, but we will not miss the some group that might be the rapid progressive group or the patients with underlying pathology as shown in the study, which this group we might have the benefits of the pubertal blocking. So I will summarize this. For the diagnosis, the age of the referral for CPP might be 8 years in girls and 9 years in boys, but in the age around 7 or 8 years, we have to define if they have the early puberty, just early normal, or they have the rapid progressive puberty, and I will discuss later.
So thank you very much, Dr. Tansit. I think I agree with you that the cutoff could be the same, but for the one that quite like marginal, for example, like 7 to 8 years, the management has to be tailored to fit with patient's condition, right? Yeah. So come to the second question. I think like since GnRH stimulation test is the main test for diagnose CPP, but sometimes the test is not that straightforward. Could you give us a tips or tricks for performing and interpreting this test, please?
Okay. So as we know that the GnRH stimulation test is the gold standard for diagnosis of the CPP, right? Because we shortage of just the GnRH, so now we use the GnRH analog, the low dose of 0.1 milligram subcutaneously for testing. And for now, if we do the GnRH testing, and in Thailand, we based on the study in Ramathipati, Bangkok, that we will show that after injections of GnRH analog subcutaneously, the LH response will rise around 60 to 80 minutes after the injections. And we found that the level of the peak LH in the CPP patient are significantly higher in the premature TILA that show that the level of the peak LH after simulation can be used for the diagnosis of CPP. In this study, they show the cutoff as well and in the basal LH, and they found that they used the two cutoff level, allow more than 0.2 and 0.3, and they see the quite specificity even in 0.2. And this study, they also perform the cost analysis. That means, and they found if we use just use the basal LH instead of to do the GnRH stimulation test, if the basal LH more than 0.2, and after followed by the GnRH stimulation test, if some in the patient in the basal LH less than 0.2, they show that in this way, this protocol can reduce the cost of the diagnosis in CPP instead of do all of the go with the breast development with the GnRH stimulation test every goes. Mm-hmm. So I will summarize this diagram how we approach these patients in the precocious puberty after carefully history taking and fetal examinations. If the clinical features are highly suspected CPP, we can do the basal LH first. If the basal LH more than 0.2, this means the HPG axis is activation, and I think CPP can be diagnosed. But if the clinical is highly suspected CPP, but the basal LH is less than 0.2, you can go to the GnRH stimulation test after that. And if the peak LH more than 5 that I showed in the last picture, the CPP can be diagnosed as well. So I think it's just two steps. You do the basal first, and if basal cannot answer your diagnosis, you can do the GnRH stimulation test.
So, yeah, thank you very much. Yeah, that is a very useful tips, and not only about interpretation for the GnRH stimulation test. Dr. Tansit also showed that basal LH can able to discriminate between CPP patients and like the one that have like pivotal variants, for example, right? So thank you very much. So come to my last question. I think it's going to be like the challenge one a little bit. So if you have CPP girl with were diagnosed at or after the age of 8 years, I was wondering whether you are going to treat them or not and why. Please, Dr. Tansit.
Okay, I think this is a quite tough question, and many people are wondering with these questions. First of all, I will say that, as I say in the previous slide, that the definitions of precocious puberty, we have to look at the age of onset. We should not use the age that we see the patients, right? Why I say that? Because when we found we always found some patients that might come in the our clinic very late, that they might have the breast tenure around 3 or 4 at the age of 8 or 8 years or 8.5 something. But it means that the tenure age of 3 or 4 is mean that they might have breast development earlier than that. So the onset not 8 years. So the onset might be 7 or 7.5. That means that they have an early than normal of the populations. So this patient also can be give the diagnosis at the precocious puberty. But the next step we need to consider, as I say, we need to consider whether they need the treatment or not, that I show you in the next slide. So we back to the goal of the GNS treatment in CPP. The goal, the main goal is to preserve the genetic growth and to prevent short stature in the adulthood, right? And the other indication might be the reduced psychological outcome, which now is still weak. And I think we need more data about that. So the main outcome, we need to look at the final adult height and prevent them not to be short stagers. So from the guideline, they might say that the onset before the age of 7 years old, the benefit of height gain is significantly proven, right? But the problem in start with the puberty start around 7 to 8, the benefit of height gain is controversial. So why I say that? Because as I show you in the first slide, that the secretin is decline continuously. So in some patients that the onset around 7 to 8, they would be the early but normal of the puberty as the secretin decline. But there are some groups that we can call the rapid progressive or even early and fast progressive of puberty. But in this patient and this group, I think that might be the benefit from the GNS treatment to stop the pubertal progressions. And what is the definition of the rapid progressive? The rapid progressive is the patient that I showed this one. They might have the breast after the 8 year, but rapidly develop to stage 2, stage 3, and stage 4 within the 3 or 6 months. And they might have the breast around 3 or 4 before the age of 9 years. And in some countries, they might use the age of menarche to define the rapid progressive. If they have the menarche before 9 to 10 years old, they might have the rapid progressive. And some patients, we can use the predicted adult height. That mainly I use this criteria to look after the patient with the CPP. In the patients who have the predicted adult height less than mid-parental height, or when we follow up, the predicted adult height decline after doing the follow-up, this patient must be considered as the rapid progressive puberty, because this might affect the final adult height. So in this group of rapid progressive puberty, they might benefit from GNS treatment, although they have the early puberty or have the puberty around 8 years. And this is the study from Dr. Karn as well, Dr. Karn group. They found they used the treatment at the girl with present with CPP around age of 8.1 to 8.4, and if they have the predicted adult height lower than mid-parental height, as shown here. And the treatment of GNS almost 2 years, and resulting that they can improve near final adult height to cross the mid-parental height, and the final adult height increased by 2 centimeters compared to predicted adult height. So this study showed that in the early puberty group, we must treatment in the patient with rapid progressive that might be have the lower predicted adult height from the mid-parental height and might have the benefit of high gain, even they not have the not significant or a little high gain when compared to in the onset early than 7 years old. So in my opinion, in summary, I think we have to define two groups in slow progressive and rapid progressive. And in rapid progressive, the benefit of GNS treatment in terms of the high gain might be benefit.
Yeah.
Thanks.
Yeah, so I agree with you that actually like defining patients with rapid progressor might be a good idea to see that these patients needs the treatment or not. And the other thing that I can share my experience is that sometimes patients have the onset of puberty quite early, but whatever reasons, they come to us quite late. So if we stick to the criteria that if we diagnose them at 8 years for the date of diagnosis and you are not going to treat them, probably this group of patients might miss the benefits of the GnRH analog treatment probably. Yeah.
So we're gonna switch to share the slide, right, Dr. Karn?
Yes, so because after this, I'm going to be the one that answer the question. Yeah, so kind of nervous. Okay, so let me share my slide. Yes.
Okay, are you ready for answer my questions?
I think I will try my best.
Okay, I will. Then we have a 4 questions for you. So let's start with the first questions. In the CPP patients with menarche, do you think we need to treat them, or do you not treat them? Do you have any criteria or any consideration for this patient?
Okay. So let me answer this question by start with I would say that there is no clear-cut answer for this question. However, I can show you something. So I think in general, everybody knows that onset of menarche is more closely related to an individual's born age rather than the chronological age. This is one example. This is the study from China, recruit about 700 girls and focus on the menarche age, or like the time of menarche. And you can see that when we focus on the chronological age, the age is wide range from 8.5 years to 13.2 years. However, this group of patients always have born age approximately around 12.4 to 12.8 years, which actually very narrow range, which means that regardless of the chronological age, the born age at menarche was stable. And if we consider the born age 12.5 year, it is the percent of mature height of girl at this born age is approximately about 95%, which means that they have only 5% left to grow. That I would like to say is that probably GnRH analog treatment, if you want to improve the height outcome at this stage, might not be kind of beneficial. And this is going well with this study focusing on the final height outcome of CPP girl treated with GnRH analog treatment. In this study, they stratified patients into 4 groups according to the born age at the end of GnRH analog treatment. And you can see that if we treat patients beyond the born age above like 12.5 years, we cannot get any further benefit in terms of height outcome. In addition, we might have a negative impact on statural growth as well. Therefore, according to the consensus guideline, they always say that if the born age is above 12.5 years in girl, so GnRH agonist treatment probably not indicative for this group of patients. So far, I have to conclude that there is no clear-cut answer for this question. However, if you think about the height outcome, I personally think that it depends on the patient's bone age. For example, if you have patients come with menarche, but bone age is still below 12.5, for example, I think this group of patients, if they have poor predicted adult height, they might get some benefit of the GnRH analog treatment. But if the bone age of patients is above 12.5 years, I think height benefit following the GnRH analog treatment is kind of negligible, and the treatment probably not recommended. However, if you're concerned about the psychosocial distress and you would like to stop the menstruation, this is the different story. Of course, to stop menstruation, GnRH analog is effective, but it's come with the higher cost compared to the other treatment modalities that can also stop menstruation effectively as well. For example, the DMPA injection. So if you would like to use the GnRH analog to stop menstruation alone, you have to discuss this issue with the parents and patient. The other thing that I would like to point out is that according to the evidence so far, distress occurring with early menstruation may not be as common as we think. And to reduce psychological distress, just only stop menstruation by medication is probably not enough. But the other way that might be a little bit better is you have to well train your child by a good parents that have calm and reassuring personality in order to make sure that your child can cope with the early menstruation. This is also the other key of success as well.
Thank you, Dr. Karn. Yeah, I'm agree with you that we have to look at the bone age mainly in terms of the height gain, but psychological problems, preparing the children is the best thing that we need to do. Okay, so we are gonna go to the next questions in the early puberty. So this is quite a common and have a question in this group. How do you decide to treat or not treat in some patients with early puberty?
Yeah, thank you very much for the question. So I have to say that this is kind of area of uncertainty, and you already mentioned some of that. So first, about the definition. So I also have to say that the definition also vary among publication, but the well-accepted definition of early puberty is the puberty that start close to the age of 7 or 8 years or later. And the other thing that also controversy is that to treat or not to treat. So I would like to answer this question by showing you one paper, which actually come from the group of Dr. Tansit and also Professor Somjit from Songkhla hospitals. So they recruit 104 Thai girls that have breast onset about 8 years, which defined as these patients have early puberty. They didn't treat them, but they follow up them until the patients reach near final adult height. And what they found is that in general, girls with early puberty attain near final height similar to their genetic potentials. However, 1/3 of the patients reach near final adult height a little bit shorter than target height. And the characteristic of these patients are, first, they are overweight. Second, they have lower pubertal height gain. And last, they were likely to have more advanced bone age and more rapid pubertal progression. And I think the other studies, some of them also agree with this kind of results, is that patients that have rapid pubertal progression, even the early puberty, probably have poor height outcome and might be benefit from GnRH analog treatment. However, when we take a look in the meta-analysis that analyze about the height outcome comparing between early puberty group that treat with GnRH agonists compared to the untreated group, overall, we found that the mean difference of final height doesn't different compared to the group of treat and untreat, because you can see that the 95% confidence interval of the mean different final height include 0, right? So then it means that there is no effect of treatment in terms of height outcome. Even in the group that have predicted adult height below 155 centimeter, which actually means that this group of patients have very advanced bone age at the onset of the treatment. And yeah, even by that, this group of patients still have no benefit from GnRH analog treatment. To conclude that, I think first, the definition of early puberty varies among publications. The other thing is that effect of early puberty on final adulthood is so far inconclusive. But this is based on a limited number of publications. In general, girls with early puberty seems to have normal final height regardless of the GnRH analog treatment. However, if you really would like to treat these patients, so the group of patients that might benefit from GnRH analog treatment is the one that have rapid pubertal progression and rapid advanced bone age, which result in poor predicted adult height. But further study are needed. And if you're gonna start treatment in this group of patients, you really have to discuss with parents and patients before starting the treatment to discuss about risk and benefit.
Thank you. It's very nice data. So the next question, we're gonna have in some group it treated with the GnRH. In some group they have the suboptimal control. That means some progression of puberty. In this patient, what you're gonna do? Do you shortening the dosage interval, shortening the interval, or increase the dose of the GnRH, Dr. Karn?
Okay, so first to answer this question, I would like to clarify the definition of inadequate suppression. Right? So according to the clinical practice guideline, we define patients that have inadequate suppression if the patient have first clinical pubertal progression, second, lack of growth deceleration, and third, still have bone age advancements during the time that patients get the GnRH analog treatment to stop puberty. And according to the clinical practice guideline, they say that only these clinical grounds alone are enough to define inadequate suppression. However, if you really would like to have the biochemical confirmation, you can also do the GnRH stimulation test. And if we find that LH peak is above 4 international unit per liter, you can also confirm that this patient has inadequate suppression. And what could we do? So I kind of summarized from like many places. Some of them are like experts' opinion, and I can show you that there are 3 main ways that you can do to manage this problem. The first thing is that switch to more potent GnRH analog. Second, increase the dose of GnRH analog. And last, reduce interval of GnRH analog injection, for example, from 4 to 3 weeks, from 12 to 10 weeks, or even change from the regimen from tri-monthly to monthly regimen, for example. So first, I can show you that the GnRH analog that are available in the market nowadays, they are the group that have high potency and also the one that have kind of immediate potency to suppress the gonadotropin. So if your patient have inadequate suppression and this patient is currently treated by the intermediate potency of GnRH analog, it is sound theoretically correct to switch to high potency one. But I would say that so far there's no RCT proven to confirm this. Just only one small studies that compare between the outcome of the CPP patient treated by the high potency triptolurine and intermediate potency leuprolide acetate. And you can see from the table that to get the same or like similar outcome in terms of height and also the biochemical suppression, you need higher dose of leuprolide acetate, which suggests that if you want to fix the dose, because sometimes the dose you cannot change because it's come in the like one vial, and if you would like to increase the dose, it means that you have to inject more shots, right? So if you would like to fix the dose, but need like better suppression, you probably consider to switch to the high potency medication. This one way that you can do. The other thing that I would like to show you is that the comparison between the CPP patient that treat with standard 11.25 milligram tri-monthly and the high dose 22.5 milligram tri-monthly in terms of biochemical suppression. You can see that the higher dose give the better biochemical suppression. So it sounds logical that if you have the patients that inadequate suppressed by the standard dose 11.25 milligram tri-monthly, you might consider increase the dose to 22.5 milligrams to help control the disease. The other thing that you can do, you can see from this table that I highlight, is that compare between monthly injection and tri-monthly injection. You can see that monthly injection, which actually more frequent, have a little bit better biochemical suppression compared to the 11.25 tri-monthly injection. So this is come to the other possibility that you can do, is that if the 11.5 tri-monthly injection cannot control the disease, so you can switch to the monthly regimen. But it doesn't mean that 11.25 is not good. So I think in general, 70% or almost 80% of the patient can be able to suppress by the standard 11.25 milligram tri-monthly. But if you encounter the one that cannot control by this standard dose, so you can choose what you're going to do. And I would like to say that so far, there is no evidence to answer that which way is better. It depends, I think it depends on your preference and also your patient's preference as well, that you have to discuss what are you going to do. But there is one paper that proposed the way that you can manage for the inadequate suppressed group. For example, if you start the treatment the patients with tri-monthly GnRH analog 11.25 milligram, and you encounter with the inadequate control situation, you can switch to monthly injection with the standard dose of monthly is 3.75 milligram. And if you still have inadequate control, you can increase the dose to 7.5 milligram, for example. This is one way that you can do.
Thank you. So we come to the last question, right? So the question is, does the treatment can cause the infertility? Because some parents concerned about this very much, right? Okay, do you have any opinion or data about this?
Yeah, thank you very much. And it's kind of logical to concern about this, right? So I first have to start with the in general of the pubertal restoration and menstrual restoration after GnRH analog treatment. I think everybody knows that actually it's quite safe, and the pubertal restoration is quite good after stop the treatment. So most studies report 100% occurrence of the menarche, and most of the time spontaneous menstruation occur about 1 year after the end of the treatment. However, in terms of fertility, it's kind of quite challenging because the data so far is quite limited, and most of them are come from kind of very small studies. One study that I would like to show you is the preferred study, which studied the adult that used to be treated by GnRH analog triptolurine during the time that they were young and they diagnosed with Central Precocious Puberty. So the study recruit patient back and asked them about the experience in terms of contraception, in terms of pregnancy, that I would like to say. So they kind of observe that for the group that would like to be pregnant and they stop the contraception, so how long that they have to wait until they become pregnant. And you can see from this chart that almost or more than 80% of patients that would like to be pregnant can be pregnant within a year after they stop contraception, which actually are comparable or similar to the general population. Therefore, this study concludes that CPP treat during childhood with GnRH analog triptolurine does not negatively impact women's fertility in adulthood. And I think this is one evidence that we can show that the fertility is not a problem after we treat patients with GnRH analog treatment.
Okay.
Yeah, and I think this is all of our questions that we prepare to answer about the CPP management, right, Dr. Tansit?
Yes, and I think yes, I hope that everyone can have experience and can answer some questions in management in CPP. And I think we're happy to answer your questions and to sharing the experience. to treat this patient.
Yeah, and I think now it's time for the live Q&A session. So if you have any question, I think we are very welcome and we're gonna do our best to answer them, right?
Yes.
Yeah, so thank you very much.
Thank you.